Okay.
You can just do it right there. I like it.
All right. Good morning, everybody. Welcome. My name is John Schmitz. I'm the annual meeting program planning chair. I just wanted to take a few seconds to again welcome you to Pittsburgh and to the annual meeting. This is a really unique opportunity for both groups. I hope you take the opportunity, speaking for the ASHI people, take the opportunity to go to the Banff sessions and learn some of the pathology that goes on in concert with the work that we do in the clinical labs. I also wanted to just take a moment to recognize the enormous number of people that spent a great deal of time to put this meeting together. I specifically want to recognize the ASHI Banff Steering Committee that's really helped define some of the joint plenary sessions that we're having here today. So Mark Haas, Jake Idris, Alex Cookie, Michael Mengel, and Anant Tambor, thank you for your efforts in this regard. I also want to acknowledge the Program Planning Committee. The ASHI Committee is nearly 20 individuals that spend a great deal of time identifying the speakers and putting the sessions together. Thank you all for your efforts in that regard. There's a huge number of people that are involved in reviewing abstracts, planning the award sessions, so on and so forth, so thank you for that. And lastly, I want to acknowledge the staff at AH for the incredible job they do pulling this all off. This has been a challenging one this year with the larger size and the greater number of sessions. So I want to just specifically mention to Kathy, Mandy, Cheryl, Shana, Jessica, Caroline, Victoria, and Melissa, thank you all very much for your efforts. I know you're going to have a busy week, but I wanted to thank you up front so we have a nice crowd here to acknowledge you for all the work you do. So now it's my pleasure to introduce our keynote speaker for this year's meeting, Dr. Robert Montgomery. Dr. Montgomery is a professor of surgery and director of the NYU Langone Transplant Institute. He received his MD with honors from the University of Rochester School of Medicine, and a doctor of philosophy from Balliol College at Oxford University in molecular immunology. Dr. Montgomery completed his general surgical training, multi-organ transplant fellowship, and a postdoc fellowship in human molecular genetics at Johns Hopkins University. And for over a decade, he served as the chief of transplant surgery and director of the Comprehensive Transplant Center at Johns Hopkins. Dr. Montgomery was part of the team that developed the laparoscopic procedure for live kidney donation, a procedure that has become standard throughout the world. He and the Hopkins team conceived the idea of domino-paired donation, the Hopkins protocol for desensitization of incompatible transplant patients, and performed the first chain transplant started by an altruistic donor. He's considered the world expert on kidney transplant for highly sensitized and ABO incompatible patients who are referred to him for the most complex cases. Dr. Montgomery has had clinical and basic research support throughout his career. His academic interests include mechanisms underlying the immunomodulatory effect of plasmapheresis, tolerance protocols, including simultaneous solid organ and bone marrow transplantation, and gene and cell-based therapies. Among his awards and distinctions include a Fulbright Scholarship, the Thomas J. Watson Fellowship, memberships in Phi Beta Kappa and Alpha Omega Academic Honor Societies. He's been awarded multiple scholarships from the American College of Surgeons, the American Society of Transplant Surgeons, and the National Kidney Foundation of Maryland has recognized his contributions to the field of transplantation with the Champion of Hope Award and the National Kidney Registry with the Terasaki Medical Innovation Award. So join me in welcoming Dr. Montgomery as our keynote speaker.
Good morning, and thank you for that nice introduction. I want to thank the organizers for inviting me. So you all came out to listen to me this morning. The guy who died 7 times. Maybe he'll have something interesting to say. Maybe he'll tell us that there's a God. Well, I'll confine my comments today to lesser deities, but we could have a conversation at the bar maybe tonight. So, these are my disclosures. So I just want to start by introducing you to my family. So, my dad came back from World War II. He was he flew bombers in the South Pacific and married my beautiful mom. And they had these 4 boys. I'm the one on the right side of your screen. He looks a little like Eddie Munster. Youngest of the 4 boys. And I have 3 biological children. Max and John and Liz, and 2 beautiful grandchildren, Rowan and Lily. And my father died from dilated cardiomyopathy at the age of 52 when I was 15 years old. And then my brother, who's on the left of your screen, that has the SD on his for sudden death, died at age 35 when I was an intern at Hopkins. And that's when we realized we had a problem. And his 2 daughters, my 2 nieces, are on the left side of your screen. My oldest brother, who was always the luckiest among us, has escaped this disease. But my next oldest brother, who's in the forefront with a little heart on his lapel, had a heart transplant 25 years ago, and then I just had my heart transplant almost exactly a year ago. And we know that my 3 biological children have the allele, the mutated allele for the disease, and as well as my 2 nieces. So this is sort of the timeline, the progression of my story and my disease. So I mentioned my father's death in 1976, and then my brother's sudden death in 87. Our family formed a foundation, actually, that started to raise money for research, genetic research. And in fact, that ended up resulting in the identification of the gene in our family, which is called RBM20, which was discovered in 2009. And it's a single amino acid substitution in exon 9 of an RNA binding protein that handles the big cytoskeleton proteins, assembly of proteins like titin in the heart, so it's cardiac specific. So after my brother's death, then I got on a treadmill and had sustained ventricular tachycardia on the treadmill. And I had one of the first ICDs implanted in my abdomen as a second-year resident at Hopkins, which was about the size of a Coke can, and I had a thoracotomy to have patches put around my heart. I was the first surgeon in the world to receive an ICD, and for those of you who might not know, that's a defibrillator, an implantable defibrillator. And they thought my surgical career was over and sort of sent me off to Oxford. My chairman was very gracious, said, well, let's just see what's going to happen, probably thinking that I would die soon. I went to Oxford, had this amazing experience, and came back. And they were concerned that this would pick up the electrical interference in the operating room and would go off, which turned out not to be the case. So I finished my surgical career. Things kind of pseudo-stabilized for quite a long period of time. I had a family, did many things that were mentioned in my introduction. And then in 2010, I was in the mountains in the Andes, and I had sustained VT and a syncope event and was shocked. And then, believe it or not, I continued to go back there every year in the middle of nowhere. And in 2017, I collapsed up in the mountains with a pseudomonas sepsis and cardiogenic shock with an ejection fraction of 10%, and was on a ventilator in a coma evac me and brought me back. I had to learn how to walk again, talk again, all the basic stuff. Lost 45 pounds. And then was okay for about a year when I went to a Broadway show, School of Rock, and I had sustained VT about 20 minutes into the show. It was quite a scene. And had multiple shocks. My defibrillator didn't work, prolonged CPR, broken ribs, broken spine from CPR. But kind of shook that off and recovered from that. But then went on to develop some heart failure symptoms. And then I was in Italy giving a talk in August of 2018. And I had ventricular tachycardic storm, and I kept arresting. And I went to this little hospital in the middle of nowhere, and priest was the first person who greeted me in the last rites. But somehow I made it through that. Flew back with one of my good friends. The Italians were so great, they left my IVs, and I signed out AMA the next morning and said, look, I gotta get back to the States and get a heart transplant. And they left my IVs and gave us all these resuscitation medications to take on the thumbs of flight. Anyway, so just a year ago, then I had my heart transplant. So I'm going to tell a series of stories, and this is the first one. And this is a curve of the deceased donor deaths from drug overdoses by calendar year in the U.S. Okay, and I'm going to take you all the way back to 1999. And there's a little excerpt in the middle of the graph from my op note from this patient that I transplanted in 1999 with a CDC high-risk donor, IV drug user who was an 18-year-old. And the paragraph just tells you sort of about the balance of risk, the argument that I went through in my mind and in the discussion I had with the patient. But at this time, remember, there was no NAT testing, there was no nucleic acid testing, so we were dependent on serologies. So there was a long window period. So somebody who was found with a needle in their arm, they could test negative for HIV and hepatitis C, but the window period was 3 to 6 months, so they could have been infected before. So this was controversial back then to use these organs, and actually the senior people criticized me quite a lot for using these organs in this young woman who had terrible type 1 diabetes and was going blind and was going to die young, and I thought it was a reasonable thing to do. So when I then became chief, I really started to focus on this, all these organs that we could potentially use that were being discarded. And so Dori Segev's group really tried to drill down and see exactly what the risk was, because I felt like a lot of what we were dealing with was emotions. It wasn't based in facts. And so they were able to determine that the risk for HIV transmission during the window period, now we're fast forwarding a bit, now NAT testing, we did a lot actually, Dori did a lot to get NAT testing throughout the country because that was a very slow process. But with NAT testing, the risk was about 5 in 10,000, which is about the risk that you take on if you donate a kidney or drive a car, okay? For hepatitis C, it was about an order of magnitude greater, 32 in 10,000. But still, we all know what the risk for our patients of dying waiting for an organ is. And so in certain patients, the balance of risk favors using these organs. So we set about then, led by Andy Singer and Bonnie Lanzi, to really try to utilize these organs from CDC high-risk donors. And during a period of about a year and a half, we did 50 CDC high-risk kidney transplants out of the 175 kidneys that were performed without any seroconversions. And I think when this paper was published, people really started to think much harder about using these organs. about the time when these organs, looking at what the actual risk was, and then a group, using a lot of these organs, were coming out, we saw this exponential increase in the number of deceased donors from drug overdoses. The opioid epidemic had started in the US. And 25% of those donors were hepatitis C positive. And 50% of those hep C positive organs were being discarded because there were way more hep C positive donors than potential recipients who were hep C positive. Wonderful organs being discarded. And in 2018, there were almost 50,000 overdoses in the US. That's more than the number of people who died in car accidents. So, this gentleman, Niraj Desai, who was one of our surgeons at Hopkins, had been coming to me, over the years saying, hey, what do you think about using hepatitis C positive organs and hepatitis C negative recipients? Well, at the time, we were still, in the pegylated interferon ribavirin era. But in 2011, this new class of drugs started to be tested clinically, the direct-acting antivirals. And that was the game changer, because this was now a cure for hepatitis C. And so Niraj and Christine Duran started this trial and did the first hep C positive kidney into a negative recipient. And did 10 transplants. All of the patients cleared their virus, and there were no significant adverse effects. So when I went to NYU, which was in 2016, right when this trial was being conducted, we were starting a heart program, we were starting a lung program, and we immediately set up with the IRB programs in all the organ groups for using hepatitis C organs and hepatitis C negative recipients. And you can see during this 18-month period, we did 102 transplants from hep C positive donors and hep C negative donors, including the first ever transplants into patients who either received a pancreas or a kidney pancreas. And how did we do? Well, everybody cleared their virus. You can see in the graph in the bottom right that it took on a median of 32 days to clear the virus. Almost all the patients became viremia because we were starting the therapy after the detection of the virus. And you can see the profound effect it had on their waiting time. The patients who received the hep C positive organs had a median waiting time of 16 days as comparison to the hep C negatives of 183 days. So I was subject number 14 in the heart trial, and I received a hep C positive heart, I cleared the virus. I took a drug called Maverick for 2 months. Here I am. But, I was back to work about 3 weeks after my transplant, doing my administrative stuff, doing research. But unfortunately, something that we don't hear a lot about, because I don't think we ask our patients a lot, I was having a really profound side effect from tacrolimus. I had a really bad tremor. Tacrolimus is a neurotoxin, and it really affected my peripheral nerves. And as you can imagine, it's devastating for a surgeon. So I was back to work, but I wasn't doing the thing that had the most meaning to me. Work is important. I think work and family largely define who we are as humans. And, my identity as a surgeon, I fought very hard for my entire career because I had this pretty profound illness. And I also felt like society had invested a lot in me and invested a lot in my family, and I think there's an implied responsibility to give something back, and I wanted to be full again. Less than 20% of our patients, our kidney transplant patients, go back to work. Can you believe that? It's amazing, isn't it? That needs some work. And if they're out of work when they get their transplant, it's even smaller. So I tried various things. I tried Envarsus, the sustained release tacrolimus, and beta blockers and things like that, but it wouldn't get me to a point where I could do a vascular anastomosis. So then I reached out to you guys, many people in this room, and at meetings and over the phone, we talked. And I found out that the Mayo Clinic was really the only heart program in the country that was even considering managing patients without a CNI. I talked a lot to Peter. He helped me tremendously. An amazing guy. He showed me these data where he looked at over 50,000 tacrolimus levels, 100 per patient. He also looked at eplet matching between the donor and recipient of a large cohort of patients. And what he found was, you probably have seen these data, that if the tacrolimus levels were less than 5, more than 20% of the time they were measured, patients tended to develop de novo donor-specific antibody, whereas if they were more steady with their levels, they didn't. And he identified these different risk groups for alloimmunity based on the eplet matching. And of course, if you were at low risk, defined as having a HLA-DR or DQ eplet mismatch of less than 11, then you could afford to have lower prograph levels. So this is striking. Personally, it was striking for me because it told me something important. So I needed to find out what my eplet match was, and if it really made sense for me, to try to switch immunosuppression. Because basically, I was sort of everybody, would say to me, "Oh, you're doing great. Why would you ever want to do that?" Sort of like a Houdini in reverse. I was escaping from a place of safety to one of peril, right? And was this a smart thing to do? So I had Massimo do my eplet mismatches between my donor and I. I wasn't in the low-risk group, but I wasn't in the high-risk group. I was in that intermediate risk group. So I talked more to Peter, and I thought this was a reasonable thing to do. So these are my levels. You can see I'm a super compliant patient. Peter, there's nothing below 5 in my tacrolimus profile. And you can see there is this, the Mayo Clinic thinks this is really important that you have this overlap period, which was really difficult because I was on therapeutic levels of sirolimus, tacrolimus, MMF, and steroids, a lot of immunosuppression, a lot of side effects. But anyway, it worked in as much as I was able to come off the CNI. But again, I did this, with a safety net, and again, the help of my colleagues. Phil Halloran has been really moved by my story. And he writes to me all the time. I send him, little pieces of taco meat from my heart, and he does his molecular microscope, and this is my 6-month biopsy, and then my biopsy right after I came off of the tacrolimus, and he's always cheering me on. But, these things that I dabbled in while I was trying to get back in the operating room, this is the future of our field. I had allomaps done during that time of conversion, and you can see they did go up, but still they've sort of settled out now. I've had a couple more since I made this slide at 30. And as you probably know, this is a gene set that it has a high negative predictive value. So if it's below 35, then there's a relatively low risk that you have rejection going on. Again, there's no serum level that will tell you if you're in trouble with a heart transplant, right? There's no creatinine, there's no transaminases. So they're completely dependent on putting a catheter in your neck into the heart and taking chunks of the heart muscle. So, when you're doing something like I was doing, this gave me a tremendous sense of, that this was going to be okay. And this is the ASHI, which is cell-free DNA test where they look at the SNPs from the donor and the recipient and look at the relative ratio of the two. And that was reassuring too. It was below their threshold for concern. And guess what? The tremor went away immediately the day that I came off of tacrolimus. The veil was lifted off. It was an amazing change that occurred. And this was the first case that I did a couple of weeks ago. That's my wife next to me. And in the foreground is the first transplant that I did. A gentleman who I'd become friends with because Ned Krause, you'll recognize him, he took care of him for years. We transplanted him years ago at Hopkins. He became a friend. He trained my dogs, and anyway, and that was a little snowman made out of the ice, the kidney ice in the donor room that staff had all set up for me when I came over. That said, "Welcome back, Bob." So many of you know that this is the 50th anniversary of this tremendous contribution that Paul Terasaki made. But there was an unintended consequence of this contribution, and that's that we identified these patients who were then warehoused on transplant lists throughout the world. And these three amigos, have been working on this really since the 1990s and have become a couple of my closest friends, Stan Jordan and Denny Klotz. And we created this underclass of patients who have limited access to transplantation. I call them the untouchables. Not the three of us, although we sort of look like the untouchables. And as you know, the size of this group has varied throughout the years. And it's really been defined and reshaped by major advances, many of which were made by the people in this room in the technology of HLA antibody detection and in the ability for pathologists to diagnose antibody-mediated rejection and HLA-related injury. And also major innovations, things like kidney pair donation and the new kidney allocation system. So you're probably aware that in 2014 in the US we introduced this new way of trying to even the playing ground for highly sensitized patients. And at a CPR of 98%, there's this high level of points that are given to patients, allocation points, to give them an advantage, basically so that they will have access to the rare genotypes. Because those kidneys, nationally, were going into people who didn't need those genotypes, whereas we all know we're sensitized against common antigen, and these highly sensitized people need rare genotypes. And initially there was a big bolus of the easier in that spectrum of difficult transplant patients. We transplanted a lot of the easier ones, and there was a bolus, and then it sort of came down again. So now we're looking at some work by Carrie Shinstock, which hasn't been published yet, but looking at this group of patients who have a CPRA of greater than 99.9%, and what their fate is. And you can see that they're more likely to die or to get too sick to be transplanted than they are to receive a transplant. And that's important because we're now starting to define the patients who need some other intervention that is not going to occur through KAS or kidney pair donation. And I think, you know, the future of this is that, again, there will be these patients who are going to need desensitization. And I think, you know, drugs like imlifidase or IDIS, with some new trials that we're about to start to try to prevent the rebound that occurs after the IDIS wears off and those plasma cells are still starting to produce antibody again. And I think that, you know, this is the most efficient way to desensitize a patient. You could take any donor and any recipient and give the recipient this drug, highly sensitized recipient, and everything would be great for 7 to 10 days. So you will not get a hyperacute rejection. So I read this book quite a few years ago, The Inventor's DNA, and it talks about the different types of people and major advances, major innovations in history. And there's a certain type of person that they define as a disruptive thinker, and I have some pictures here of people who were involved in some of the work I'm about to talk about, who I consider to be the disruptive thinkers. In 1995, Lloyd Radner and Lou Cavussi pioneered this new operation, and I was lucky enough to sort of come along for the ride with them. And you can see Lloyd and I, one of the early lap nephrectomies. And you can see what happened to the number of live donor transplants that we did at our center once we started to do this procedure. And this has been adopted throughout the world and has really revolutionized donation. This young woman was at one of Lloyd's lectures on the laparoscopic nephrectomy. And she had been thinking about donating her kidney, but didn't know anyone who needed a transplant. And then when she heard that there was this new breakthrough in the technique that made the recovery for the donor much easier, much better, she said, okay, I'm going to do this. So she came to Hopkins with a publicist. She wanted to start a revolution. She said, I want to give my kidney to anybody who needs it. And so we allocated her kidney to this 13-year-old child. Now, there was no roadmap for this at the time. So the next day, guess what? She was on the evening news and everything. We had 50 people call and say, I want to donate my kidney to anyone who needs it. And so we started to say, okay, we're going to give them to our kids, right? Makes perfect sense, right? But we ran out of kids. So at the same time that we were going through this, we also had started this incompatible program. And there was a eureka moment where we thought about this, which is, what about if we have a non-directed donor, an altruistic donor, give to a recipient who has an incompatible donor, and then that person can give to the person at the top of the list. And we started to expand those chains then through various iterations. And it got a lot of national attention, and W, invited us to the Oval Office. We had the ceremony. It's a funny story. I'm holding up that T-shirt there. It says, "The miracle shop never closes." Transplantation at Hopkins, and the White House had sent a bus to come and pick me up. I was a bachelor at the time, and I was living in this loft. And one of my friends ran out and said, "Hey, it's time to go." And I said, "We don't have a gift for the president. I can't believe I didn't think of that." So I said, "Well, what about one of those tie-dye T-shirts that we made?" And so I went, and looked, through some drawers, and it's like, oh my God, I can't, And then I looked in the hamper. Anyway, yeah, you guessed it.
So today, you are not 15 individual doctors, you are one team of surgeons representing this hospital. Is everybody clear on that? Why are they needing so many doctors for one surgery? Because it's not just one surgery, it's 12 surgeries. 6 kidney transplants and 6 ORs, all at the same time. Paired matching kidney donation. Just 6-way swap. 6 people donate kidneys to total strangers. 6 people get kidneys from total strangers. 12 people walk away happy. Paired matching kidney donation.
Otherwise known as abdominal surgery.
Our 6 donors are all anesthetized and ready to go. They'll be done first, followed by the recipients. Each pair will be color-coded so as not to confuse them. This surgery is a hornet's nest, people. So work quickly but carefully. Use each other. Operate as a team. Let's go make medical history.
So, the funny thing in this next video that I'm going to show, the funny thing is that, one of the first reality shows ever was Hopkins 24, which was made in the late 90s. Anyway, the second round of that, they featured one of our swaps. Actually, it was the first swap where a live donor kidney was transported. I flew all the way out to California on a Lear jet, picked up the kidney and brought it back. So ABC had all this footage, in their library when they made that Grey's Anatomy series. So watch this.
Right, so now this is the really important part, which is we're hoping it's going to start to make urine right away, but since this has never been done before, we don't know whether it will make urine right away. There it is. Woo! Never get tired of seeing that. Never get tired of seeing that. It's like the first time, every time.
Want to do the honor start tonight? Good. Time coming off.
That's quite a geyser of urine, sir.
That means we did our job right. Never get tired of seeing that.
I made no money on that. So then one of my colleagues, Michael Reese, said, okay, this is great. You're doing all these, you're using 12 operating rooms at Hopkins. Where else could you do something like that, doing all these chains simultaneously? And he introduced this idea of the non-simultaneous extended chain where organs could then be moved from one place to another, and a donor would become a bridge donor and extend the chain at a later date. And so we started to do this. We did this first series with Michael, and then we moved on to other things. We were happy about this. But again, this book that I referred to earlier, we brought this to a point where it really took a different type of person to extend it to its full possibilities. And these are the executive thinkers. These are the people who can organize, who can scale, build policies and procedures, increase the yield, and really implement this on a wider basis. Bridget Sullivan, who's been with me for several decades now, is one of these people. And so, as it turns out, there's this guy named Garrett Hill, who directs the National Kidney Registry. And again, I sort of had lost touch with Garrett over the years and didn't really know what exactly he was up to, but knew that they were being very successful. And then one day he presented, kind of the state of things to me of what they had been doing. And, this is an amazing example of scaling and delivering an innovation so that it is accessible to people. And these are sort of the 4 pillars of what they do. They provide protection to the donors with insurance and things like that, things that we've been asking our government to do for years. They've automated the workflow. They use, algorithmic approaches to doing the matching. They figured out what edges to weight and things like that. But the really interesting thing that they had developed, and this was because they kept having chains that failed. And so this is how an executive thinker thinks, like, okay, what can we do to fix this? So they introduced this idea of vouchers.
Standard voucher. So let's say you have a couple, and they're the only caretakers for each other. And so they're like, well, this is going to be really difficult for both of us to be patients if one gives a kidney to the other. So this idea was that the donor could just donate to the pool, and then at some time within the next year, after the donor had recovered, then the recipient would get a kidney. Right? And then they started doing family vouchers. So Garrett was, I think, the second person who did this. He has a daughter who has a kidney transplant. And we'll probably need another one in the future. She will, she's young. And he was like, well, I'm fit. He looks like a Disney prince or something. I'm in good shape now, but who knows, like next year that may change. And so he donated a kidney, and his family gets a voucher. And they're constantly looking at the liquidity too, to make sure that they're not overextending themselves. Very interesting concept. So this is what's happened. Look at now we're reaching, Dorian Summer many years ago predicted, based on simulation data and mathematics, how many potential transplants we could do. We're almost at 1,000. That's a big increase. These transplants wouldn't have occurred. 2/3 of them now are with the NKR. And look at this. So now with the introduction of the standard voucher and the family voucher, the chain lengths have decreased because they're starting more rapidly, and the swap failures have decreased. And the numbers of vouchers and the people who are using the vouchers has increased. So again, executives, thinkers, they're like, okay, we're making this thing work, but what I'm thinking is, guess what they just did? They just uncoupled donors from recipients. Okay? And I think the future is, for live parent donation, we're going to have a list of recipients, and we're going to have a list of donors. And we're no longer going to have people who are donating to a loved one. We're going to make the best possible matches. And what would that involve? Well, we go back to, Peter. It involves better matches, lower rates of development of de novo donor-specific antibody that's going to affect future transplants, a greater longevity of organs. We are now on the edge of precision transplantation. We are getting to the point where the oncologists are. Okay? And that uncoupling of donors and recipients becomes really important in order to implement this kind of thing. And now, like this guy, Brendan Keating, who is now looking at amino acid variants throughout the coding region of the genome, and looking at the similarities between the donor and recipient, which can prognosticate the survival. So now we can look outside of the HLA, right? And sequence outside of the HLA and greatly increase our level of producing more compatibility between a donor and a recipient. And then I have to mention these two because I think these two really, Alex and Carmen, you have really changed the landscape. And I think, in order to implement some of these ideas, we're going to need to be able to do clinical trials more rapidly than we've been able to do. And we're going to have acceptable surrogates. And we're going to be we cannot wait for outcomes like graft survival and patient survival. And I think the iBox is a major contribution. Okay, so what's next? Well, this is the 50th anniversary of the first walk on the moon. And I think, as humans, we can do great things if we put our minds to it. So I'll ask you, and I ask myself this every day, what am I going to do? What are you going to do? How are you going to change this landscape? I came across this life expectancy curve, which is pretty amazing, really. And I don't know if you've seen, if you've gone on that app where you can figure out what number person you are to be born since mankind.
But they have the population curve, and the population curve you could pretty much overlay. So for millions of years, the population of the world was about 500 million. And then suddenly, in like the 1920s, it just goes exponential. And this is why, because our life expectancy went exponential right about that time. Now, what happened in the 1920s? Well, there are a lot of things, antibiotics and things like that, but how profound that is. And look what the life expectancy was just 100 years ago, 30. So I'm very aware of this because I shouldn't be here, really. And I'm also very aware of my impact on the world. I'm trying to go carbon neutral. I'm doing a lot to try to change the way I think and do, because I feel like, you know, I've been given this great gift, and, you know, it's important to keep that in mind. And everybody in the room, all the gray hair in here, I mean, this is a profound thing that's happened in our lifetimes. So, what is the next moonshot? Well, I think it's the number one unmet need, which is about 40% of our patients never make it across the finish line, okay? And I was in that lucky 60% group. But it didn't have to be that way. So, it's organ supply at the end of the day. So this is where I'm focusing now. And I'm focusing on two areas. One is bioartificial organs, and the other is xenotransplantation. And, you know, we have bioartificial organs now that are pretty close to be pretty advanced near testing, the testing stage. These are scaffoldings that have human cells laid on them. You can imagine that it doesn't make a lot of sense to really test these in pigs because they've got human organs, or they've got human cells laid on a pig scaffold. So that's going to be a challenge. How are we going to test these organs to even do like the initial tests? And then xenotransplantation, you probably know with the innovation in CRISPR, we've been able to knock out the important glycans, that the enzymes for which we lost during evolution, and so we have preformed antibodies against those glycans. And we've been pretty effective about knocking them out, probably 95%. But there is some cross-reactivity between HLA and SLA, the swine leukocyte antigen. So there's certainly still going to be preformed antibodies in these patients. So I think, you know, working with these patients in the clinic is going to take a new skill set. It's not the gene people who are going to do this, and it's not the primate surgeons. It's us. All right. So then, but you know, still, one of the big problems that we have right now is that most of the preclinical primate work has been done with preconditioning and immunosuppressive regimens that have not been tested in humans, and that's a big problem. And the results have been inconsistent. And so we do have organs now, kidneys and hearts, that are out, you know, to a year and a half. But 50% of them are lost fairly early on. And then, you know, what are we going to use in the first human trials for immunosuppression? Because again, you know, the preclinical data has been done with drugs like anti-CD40 ligand and anti-CD4 and CD8 and viper venom and all these different drugs. So one of the things that we're working on now, and we're about to start this trial, is to come up with an immunosuppressive regimen that could work in xenotransplantation. And we think that the highly sensitized patient is actually a great model. So why go back? Because that's what the FDA told everybody to do now. Go back in the primates and use like real immunosuppression and show us some good results. I feel like the highly sensitized patient is a preformed antibody. They have a primed immune system against HLA, against some novel antigens as well. That's a great model to test new immunosuppressive regimen. So we came up with this tolerance protocol because I think it's going to require tolerance because this response, the xeno response, is so strong. Using bone marrow, plus itis, plus belatacept, Velcade, these things that we think are going to be good plasma cell therapy and also maybe block the peripheral lymphoid response when you deplete among the plasma cells. So we're about to start this trial. So at the end of the day, you know, the work that Zeno's been done in primates, right? That's a giant leap to go from a primate to a human being. How are we going to do that? Who's going to volunteer for that? Actually, I think if it was a little more advanced, I would volunteer for that. But still, there are a lot of people who I think would feel a lot better if there was some other way to do this. Maybe we're not using the right monkey, right? That's one possibility. We need a monkey that's more human-like. I came into the transplant center at Hopkins one day, and this was on the screensaver for all of the computers in the building. Thank you, Dory Segev. I don't know if you're here or not. But anyway, so how about the recently deceased donor? Is that an acceptable intermediate where we could do some research, in these high stakes, highly exploratory studies like xenotransplantation, like testing the bioartificial organs? Well, is that going to be okay? Well, we currently, can send families of brain-dead donors to use their organs for research, right? And we have an established practice of anatomical donation. We brought together, and others, ethicists, legal experts, religious leaders who weighed in on this, and felt that it was ethically acceptable, but it had to be done, obviously, in a transparent and open manner. And we have to be very careful about negative attention. So this has to be given great thought. We've discussed in patient focus groups the concept of xenotransplantation. I've become very much a patient advocate, and patients really feel like they want to have something in between the primate and the first living humans. And the FDA also is concerned in terms of issuing an IND. So this is what we've envisioned, and this is the trial that we're about to start in recently deceased donors. This is an ex vivo perfusion model with artificial lungs. You can see in the bell jar and the recently deceased donor's blood is circulated. They're on life support, circulated through the lungs, and various tests are done on the lungs to determine what sort of a response there is to human hemodynamics and the human immune system. And we plan on doing the same thing with xenotransplantation. And you could probably do about 48 to 72 hour study. So we're gonna enroll 10 recently deceased donors very soon. So now for something completely different. While I was going through my transplant and going through some dark times, my wife found these old love letters that I wrote to her because we had this sort of Victorian courtship for a couple of years where we wrote letters to each other. And anyway, so she took these letters and sat down with the composer and wrote a song cycle. It's called Notes from Robert. And I'm just going to show you a brief excerpt from one of those. people who have not only been involved in the work that I've described, but have gotten me to this place this morning with you. And these are just a few of them. And I want to call out, Lorraine and Mark and the pathologists who were part of that Camelot experience that we had at Hopkins, Ed Krause. Karen Kane, who passed away a couple of years ago from colon cancer. Andrea and Susie, Annette, all of these people who gave so much. And these amazing people who influenced my life, my mentors, Professor Shen's father of transplantation in China, Tom Stars and Paul Terasaki, Joe Murray, who I was the Murray lecturer the year that he died, and we had this wonderful opportunity, my wife and I, to spend an evening with he and his wife, who was an opera singer as well. David Sachs, who's doing some amazing tolerance work. Mel Williams, who was one of the people who started this whole thing and then needed a kidney transplant. And I had the honor of doing his kidney transplant when he was 84 years old. He's now 91 and he's doing great. Martine Rothblatt, who is doing a lot of this. She's just an amazing person. Google her, it'll blow you away who this person is, who I'm doing a lot of work with Xeno and the bioartificial organs. So anyone that I've forgotten or haven't called out, forgive me. It's also the 50th anniversary of this movie, which had a big impact on me when I was just watching with my brothers. And I think this speaks to many things. Tolerance, first of all. I think it speaks to, really enjoying life, because it's so important. These problems that we have, the bulk of the work that I described, it's kind of fossil fuel, right? So we've made it more efficient, we've made it better, we've made it more efficient, these various innovations and everything, but we will never solve the problem of organ availability through those techniques. So bioartificial organs and xenotransplantation, they're the wind and the solar power. They're the future. And in order for that to happen, we are going to have to come together, because right now in the world, we're becoming very tribal. And we need to come together as a community and solve these really difficult problems. And I think, the French consortium group is leading the way, telling us how you do really good international work. Phil Halloran as well. There are many examples. And this is the sort of thing that we need to do to solve these problems, but don't forget to enjoy life. Thank you.
So Bob